section on regulation of blood pressure. In that slide, I talk about fluid exchange in the systemic capillaries. And I won't go through this slide now, but I just want to point out to you that the same two forces, hydrostatic pressure and oncotic pressure, control fluid movement into and out of systemic capillaries just like they control fluid movement in the glomerular capillaries. So getting back to the glomerular capillaries, what factors are going to change or alter the glomerular filtration rate? Well, if you want to change the glomerular filtration rate, you can change either the hydrostatic pressure in the glomerular capillary or the hydrostatic pressure in Bowman's capsule, or you could change the oncotic pressure in the glomerular capillary or the oncotic pressure in Bowman's capsule. Any changes in these forces are going to affect the glomerular filtration rate, and that's the way we think about the GFR in theory. We don't usually actually measure the GFR from these forces, but we think about certain disease states that alter these forces and how that affects the GFR. Before we go any further in our discussion of GFR and capillary hemodynamics in the kidneys, we have to pause and talk about two very important structures in the kidneys, and those structures are the efferent and afferent arterioles. Normally, you have an arteriole that feeds blood into a capillary, for example, in the periphery, and then that capillary drains into a venules. The glomerular capillaries are different. They do not drain into venules. They have an arteriole on both sides. The arteriole that feeds the capillary is called the afferent arteriole, and the arteriole that drains the capillary is called the efferent arteriole. You can just remember the E for exits and the A for arrives in terms of the glomerular capillary. The reason our kidneys evolved this way is because this allows us to vasoconstrict either the blood flow coming into the capillaries through the afferent arteriole or the blood flow exiting the capillaries through the efferent arteriole. And by vasoconstriction on one side or the other, we can manipulate the hydrostatic pressure in the glomerular capillary, and that's very important for the way our body controls and alters the GFR. So now that we understand that, let's talk about what would happen to the glomerular filtration rate if we altered either the hydrostatic pressure or the oncotic pressure in the glomerular capillaries. And let's start by talking about what happens when you raise the hydrostatic pressure Pg sub C in the glomerular capillaries. One of the ways this can be done is by dilating the afferent arteriole. That allows more blood to rush into the glomerular capillary, and that will increase the renal plasma flow of blood flowing through this capillary. That will also raise the hydrostatic pressure Pg sub C. Why would this happen? Well, we're stuffing more molecules into this capillary, therefore we are going to raise the hydrostatic pressure Pg sub C. And remember, this pressure is a driving force for the glomerular filtration rate, so when we do this, the GFR will increase. And because this change, dilation of the afferent arteriole, increases the GFR and it also increases the renal plasma flow, then the filtration rate, which is the ratio of these two, is not going to change. In other words, if the GFR goes from, let's say, 10 to 20, but the renal plasma flow goes from, say, 100 to 200, we maintain the same ratio of a filtration fraction and there's no change. Another way that we can raise the hydrostatic pressure in the capillary is by constricting the efferent arteriole. So if we constrict the outflow of blood from the capillary, this is going to raise the hydrostatic pressure in the capillary because blood molecules are going to back up behind this obstruction, and that's going to raise the pressure here. That is also going to increase the GFR, just like we talked about with dilation of the afferent arteriole. However, in contrast to dilation of the afferent arteriole, less blood is flowing out of the capillary, and there's an overall decrease in the amount of blood that is flowing through this system. So in this situation, we get an increase in the GFR, just like we saw for dilation of the afferent arteriole. However, we get a decrease in the renal plasma flow, and for that reason, we see an increase in the filtration fraction. In other words, more of the blood that goes into the capillary is being filtered and less of it is exiting the capillary. What if we change the oncotic pressure pi G sub C in the capillary? We can do this if we increase protein levels in the blood. Remember, proteins, especially albumin, are very important for generating that oncotic pressure pi G sub C. If we raise this pressure, that will draw more fluid into the capillary and resist the movement of fluid out of the capillary. That is going to reduce the GFR. In general, changes in protein level do not affect the renal plasma flow. In other words, blood continues to flow through normally. It's just that less of it moves across the membrane and into Bowman's capsule when there are more proteins in the plasma. So for this reason, we see a decrease in the filtration fraction because we are decreasing the GFR, but the renal plasma flow is not changing, therefore the filtration fraction goes down. And there are many disease states where the protein levels rise in the blood, for example, multiple myeloma, and in those states there can be a lowering of GFR for the reasons shown on this slide. Now let's talk about what would happen if we change the hydrostatic pressure in Bowman's capsule. Remember, this hydrostatic pressure resists the flow of fluid out of the capillary and into Bowman's space. One way that this pressure in Bowman's capsule can get very high is if there's an obstruction of the ureter, for example, from a kidney stone. This will back up urine behind the obstruction, and the pressure in Bowman's capsule and all the nephrons will get very, very high. When this happens, there will be less glomerular filtration because of this high pressure in Bowman's capsule. There's no effect on renal plasma flow. Blood will continue to flow through the system normally, so what you will see is a fall in the filtration fraction because we've got a drop in the GFR, but we have no change in the denominator of the filtration fraction equation, which is the renal blood flow. So on this page, I've summarized the glomerular flow dynamics we've been talking about in the last few slides. There are many disease states and drugs and other situations where all these things shown here can be altered, so it's important to understand the effects that these have on renal plasma flow, glomerular filtration rate, and the filtration fraction. So if we start with afferent arterial dilation, that will increase the renal plasma flow and the GFR, but have no effect on filtration fraction. If you were to constrict the afferent arterial, the opposite effects would occur. If you constrict the efferent arterial, that lowers the renal plasma flow, raises the GFR, and increases the filtration fraction. And if you dilated the efferent arterial, that would have the opposite effects. Raising the amount of proteins in the plasma and the osmolarity of the plasma has no effect on plasma flow, but it does decrease the GFR and the filtration fraction. And then finally, obstruction of a ureter blocks the flow of urine out of the nephron, including out of Bowman's space. That has no effect on renal plasma flow, but it reduces the GFR and it reduces the filtration fraction. I'll finish this video by talking about auto-regulation of the kidneys. So over the course of the day, if you could see your blood pressure, you would see that it sometimes goes up and it sometimes goes down. Even though it's always within normal limits, if you're not hypertensive, it still can go up and down within normal limits depending on what you do. For example, when you sit or stand, your blood pressure can change. When you drink water, or if you don't drink water, your blood pressure can change. And if your kidneys weren't able to regulate the blood flow, then the amount of blood being filtered would vary widely during the day, and this would make the kidneys very inefficient. But luckily, the kidneys can do what's known as autoregulation. They can maintain a constant GFR and renal blood flow over a range of blood pressures. This is what GFR and renal blood flow look like shown on the screen here. The mean arterial blood pressure is on the x-axis, and the flow rate for the renal blood flow, or GFR, is on the y-axis. And you can see that anywhere from about 80 up to about 200, the kidneys can maintain the same blood flow and the same GFR. This process is called autoregulation. Only if your blood pressure gets very, very low do you start to see a drop in renal blood flow and GFR. And there are two major mechanisms by which the kidneys auto-regulate their blood flow and the GFR. Those are called the myogenic mechanism and tubuloglomerular feedback. The myogenic mechanism refers to the ability of the afferent arteriole to constrict in response to high blood pressure. This arteriole responds to changes in stretch, and when the pressure goes up, the arteriole gets stretched and it responds with vasoconstriction. So if we look at this drawing on the screen here, imagine that the afferent arteriole senses high blood pressure coming from the renal arteries in the vascular system. It will respond by vasoconstricting. This will allow less blood to enter the capillary, and it will maintain a normal hydrostatic pressure in the glomerular capillary despite the higher blood pressure in the systemic vessels. And the result is maintenance of normal glomerular filtration rate and renal plasma flow over a wide range of pressures. Tubuloglomerular feedback refers to the fact that anytime the GFR goes up, there's more urinary flow in the tubule, and since there's always sodium chloride in tubular fluid, this means more sodium chloride will be delivered to the distal tubule. In the distal tubule, there is a structure called the macula densa, which is part of the JG apparatus, and it senses the increased sodium delivery, and it responds by telling the afferent arteriole to vasoconstrict. So let's look at our drawing again and imagine that the blood pressure were to go up out here in the systemic vessels and that more blood flow were driven into the capillary. That would cause the GFR to go up. This would be sensed by the macula densa, which would then trigger the afferent arteriole to vasoconstrict, and we'd get the same phenomena we talked about for the myogenic mechanism. The hydrostatic pressure in the capillary would fall and the GFR would come back to normal. And this is the second major component of autoregulation in the kidneys. Here's an image of a glomerulus, and I just want to show you how close together all these structures are. So this is Bowman's capsule here, this white part right here. We've got the distal tubule out here, and right between the glomerulus and the distal tubule is the JG apparatus. That's where you can find macula densa cells, which are modified distal tubular cells. That's also where you can find the cells of the afferent arteriole that vasoconstrict. So this whole JG apparatus is sensing blood pressure and responding with afferent arteriole vasoconstriction to maintain normal renal blood flow and normal GFR over a wide range of blood pressures. I'll finish with this slide and discuss severe volume loss. So severe volume loss occurs when patients have a profound loss of fluid, for example, vomiting and diarrhea or massive hemorrhage. In this situation, the blood pressure gets very low and the renal plasma flow falls significantly. And you need to be aware that when there's significant volume loss, the autoregulatory mechanisms are overwhelmed. All those autoregulatory mechanisms basically are designed to work within a range of normal blood pressures like you experience throughout a normal day. They're not going to work if you have a massive hemorrhage and are in a state of hemorrhagic shock. So if you look at this drawing on the screen, when the mean arterial pressure gets very low down in this range, the GFR starts to fall and the renal blood flow falls. The autoregulatory mechanisms cannot keep up at these low pressures. So in this situation, the GFR will fall, the BUN and creatinine will rise, and pre-renal failure will develop. So this is often a confusing concept for students. They're familiar with renal autoregulatory mechanisms and they're faced with a question of a patient in shock. You should be aware that those mechanisms aren't going to work in the setting of severe volume loss. And that concludes our first renal physiology video.